Te acompañamos en los pequeños como en los grandes pasos de tu vida. Tenemos una manera de sentir la vida que compartimos todos. Es querer ser mejores en nuestras vidas y eso trasciende en nuestra profesión. Es una búsqueda, una forma de ser. Es creer en lo que hacemos, mejorar la salud y calidad de vida de las personas. Es una forma de trabajar con pasión, de aprovechar lo mejor de la ciencia para crear medicamentos y productos innovadores. Somos la tranquilidad que siempre va a estar de tu lado. Desde que naces hasta la plenitud de tu vida. Un camino que recorremos juntos haciéndonos más confiables a cada paso. Te acompañamos en tu nacimiento. Estamos con tu familia, tus amigos, tu trabajo y tu profesión. Y esa cercanía es lo que nos reconforta. Somos confianza en nuestros colaboradores. Somos cultura de excelencia y búsqueda de calidad. Pero sobre todo, somos bienestar. Megalabs. Somos bienestar.
My name is Jhon Mulhall. I'm a urologist. I work at Memorial Sloan Kettering Cancer Center in New York City. I specialize in sexual medicine and penile implant surgery, and I'm the journal editor for the Journal of Sexual Medicine. So there are two major challenges in the patient who's had radical pelvic surgery who goes on to have penile implant surgery. And when I say radical pelvic surgery, I'm talking about radical prostatectomy mostly. And the two challenges are the hostile pelvis. And by that I mean that when the patient has had their prostatectomy, whether it's open or robotic, that the usual space for reservoir location is often obliterated. That space is known as the space of Retzius, the pre-vesical retropubic space. And that space in many patients who've had radical pelvic surgery is gone. And so creating a space is a challenge. And there are two alternatives. The first alternative is to go through the external ring and to go cephalad, upwards, and put it below the rectus muscle, a low submuscular space, which is usually present. However, when that's not the case, or if that's not something you're comfortable with, then doing a high subrectus ectopic location for the reservoir is the next choice. Go to the anterior, superior iliac spine, make a transverse incision through the rectus fascia, and you place the reservoir beneath the rectus muscle, and you run the tubing down into the scrotum. So that's the first challenge. The second challenge is the penile length loss that occurs in many men who've had radical pelvic surgery. Those men who get penile length loss, they have length loss because of smooth muscle collagen deposition. They're also the patients who have the worst ED and the patients who require penile implant surgery. And so it's critically important that as you as a surgeon give realistic expectations to our patients before the operation. So that you must measure the penile length before the operation and say to the patient, this is your penile length, it'll never be any longer than this with the implant in place. Because the number one reason why my penile implant patients are unhappy, especially after radical prostatectomy, is my penis is not the same as it was 10 years ago. It is shorter. And that is the fault of the prostatectomy, not the penile implant. The most difficult situation in penis implant surgery is infection, penile implant infection. It still occurs no matter what we do, no matter how many implants we do, no matter what the protocols are in place to prevent it. It still occurs approximately 2% of the times. And this is a disaster, right? Typically it occurs in my practice between 2 and 12 weeks after surgery. High fevers, chills, pus drainage, new redness in the scrotum, new swelling in the scrotum. The implant must be removed. This is not the kind of infection that can be treated with antibiotics. Nearly always, in those cases, I will suggest to the patient that we do salvage implant surgery. At the time of removing the implant, we put a second implant in. That's called salvage implant surgery. And surprisingly, and even to my surprise, only 20% of those second implants get infected. Even though we've just put an implant in to an infected field that we've cleaned and we've washed out, only 20% get infected. So the people who really need to be worried are the 20% of the 2% who had the original infection, which is about 0.4%. But that still remains a major concern for all penile implant surgeons. I'm not convinced that the incidence or prevalence of erectile dysfunction has increased over time. First of all, when you look at that literature, the epidemiological literature, there are variable definitions used as to what ED is. The definition of ED, technically, is the consistent inability to obtain and or maintain an erection sufficient for satisfactory sexual relations. That is not always the definition that's used in some of the studies. The other issue that's at play is that we are much more focused in the 21st century on our sexual function. It is much less taboo to talk about it, to research it, and we're much more open about saying that we have erectile problems now than we were back in the 70s and in the 90s. So while I understand there is literature that suggests that there may be an increase in prevalence of ED, I'm not convinced that's the case. Saying that, there is an increase in vascular risk factor occurrence, hypertension, dyslipidemia, diabetes, obstructive sleep apnea, cigarette smoking, etc. All of these things are associated with ED, and as their prevalence increases, one could expect that the prevalence of ED would also go up.